Hey everyone, my name is Akash Patel. I'm one of the first year residents at UC Irvine Medical Center. I have a really interesting case for you guys actually. It's about Takotsubo cardiomyopathy. It's newly diagnosed in this patient with known stage 4 sigmoid adenocarcinoma with mets to the liver, and also has a severe persistent post-herpetic neuralgia in the left scapula. So the story goes is there's a 65-year-old man with this known cancer and this neuralgia who presents with this left scapular pain and increased nausea and vomiting. He actually presented 2 weeks prior to UCI with the same pain. He describes it as sharp 10 out of 10 stabbing pain in the posterior scapular region, and it radiates to the anterior aspect. It's not like the classic chest pain with the pressure-like sensation radiating to the jaw or the left arm, exacerbated by activity and relieved by rest, nothing like that. So the ER physicians weren't actually too concerned given that the patient presented with this 2 weeks ago. So they got an EKG because they wanted to give the patient Zofran and they wanted to make sure that his QT wasn't prolonged and there was no EKG prior. So they got this EKG, and interestingly, it showed ST elevations in V3 and V2 and V3, and then also in the inferior leads. It's more prominent in V2 and V3, and then there's these deep T waves in V2 to V6. So given this suspected new EKG changes, they sort of went down this rabbit hole, got a troponin. It was elevated initially. It was at 180 and peaked at 247. They called cardiology, and I was on the CCU service at the time, so we went down and we did a bedside echo. Bedside echo showed some suspected anterior wall motion abnormalities with some apical akinesis. So given this history of scapular pain, these EKG changes, bedside echo showing anterior wall motion abnormalities with this apical akinesis and this troponemia, the cath lab was activated and the patient was taken to the cath lab. The left heart cath showed normal coronaries actually, and they did an LV-gram and showed this classical apical ballooning concerning for Takotsubo. So we did get a formal echo. It showed an LVEF of 25%, and then this classic apical ballooning. So if you actually take a look at figure 2, you can see this apical ballooning. So this is a freeze frame of a 4-chamber view at peak of systole. So you can see the proximal portion is closer to the aortic valve, contracting, and then you see this dilation of the apex. It's ballooning during systole, so you know that's aneurysmal. So there was also concern for an LV thrombus, so the patient was started on Eliquis instead of Coumadin, given this severe persistent post-herpetic neuralgia. It was so bad to the point where it was debilitating for the patient, so we were concerned with compliance for INR checks, so we actually just started the patient on Eliquis as opposed to Coumadin. The reason why this case is so important and kind of have an idea of and just kind of raise awareness of Takotsubo is even though it only presents 2% in patients with acute coronary syndrome, and there's only 15 to 30 cases per 100,000 annually, it's very important to keep in the differential, especially when patients have known stressors, especially cancer. So it's good to have this on the differential. Interestingly, greater than 90% of patients who have Takotsubo cardiomyopathy have like this hypokinesis of the base, some degree of troponemia, and non-obstructive coronary artery disease. And what's interesting is our patient fit all the criteria. It's kind of like a slam dunk. It was really interesting to see a patient that met all of these criteria presenting with acute coronary syndrome and found to actually have Takotsubo cardiomyopathy. It's just something to keep on the differential. I know it's technically more of a rare cause of acute coronary syndrome, but especially with patients who do have known cancer and have increased stressors, to just keep this in the back of your mind when you're doing a workup for chest pain. I just want to say thank you guys for your time, and I hope you guys found this case to be as interesting as I did. Thank you so much.